Grand Rounds. It's my pleasure this morning to introduce our two speakers, Dr. Wendy Bernatavicius and Brittany Miller. First of all, Dr. Bernatavicius is our chief of the Division of Primary Complex Care and Adolescent Medicine. She's originally from Philadelphia, Pennsylvania, and she began her professional journey in the field of advertising, where she worked for 6 years while earning her Master's of Business Administration. Although successful in business, she ultimately discovered her true passion lay in medicine, so she went on to earn a medical degree from Drexel University College of Medicine in Philadelphia. Then we were fortunate that she moved out here to Phoenix, Arizona to complete her pediatric residency here at Phoenix Children's, where she was a chief resident in her third year back in the days when we had third-year chief residents. In 2008, she joined the Division of Primary Complex and Adolescent Medicine, before it was called that, and she's provided care for children with complex medical needs ever since then. And then starting in 2016, she became our General Pediatric Division Chief. In addition to her primary care work with children of medical complexity, she's also board certified in hospice and palliative medicine. She provides both inpatient and outpatient palliative care consultations, as well as hospice services in collaboration with Hospice of the Valley. Joining her today will be Brittany Miller, who's our Executive Director of the Epilepsy Foundation of Arizona, and also a patient and faculty member here at Phoenix Children's. Brittany started her journey with parent and patient advocacy over 15 years ago when her youngest daughter, Brooke, was diagnosed with Aicardi syndrome, cerebral palsy, and severe epilepsy at Phoenix Children's. After receiving invaluable support and guidance from Phoenix Children's, Raising Special Kids, and the Epilepsy Foundation, it inspired her to get involved in the Arizona disability community as a parent advocate. She's volunteered as a parent leader, mentoring parents whose children had similar medical issues, and then she applied and was accepted onto the Family Advisory Council at Phoenix Children's, where she served alongside physicians, parents, and staff for over the past 11 years. She's also active in Raising Special Kids. She works as a family support specialist. She serves on our communications team. And now she serves on the Phoenix Children Patient Safety Committee and patient family faculty. She also has participated in disability councils, and she's, as mentioned before, currently the executive director of the Epilepsy Foundation of Arizona, and is passionate about advocating for families affected by epilepsy. So without any further ado, here's Dr. Bernatavicius. And she'll be bringing up Brittany later.
Thank you so much, John. Appreciate it. So I'm Wendy Bernatavicius. It's nice to meet everyone or see everyone here. I know most of the people in the room, but some of the residents, we don't know each other. So nice to see you all in person. So today we're going to talk about changing the script, guiding parents through the no antibiotic talk. This is pretty timely because we're coming up on respiratory season. So what do we do when families come in sort of expecting antibiotics? How do we handle that? So you met me and Brittany already, and we'll be inviting Brittany up at the end. We're actually going to do like a live clinic session so you guys can see how some of the communication techniques we talk about can be put into action. So we're going to start a little bit today about antimicrobial stewardship and sort of talk about what Phoenix Children's is doing in the outpatient setting for that and how we're able to do that with the Patient-Centered Outcomes Research Institute project that we were awarded. You'll learn a little bit about that project. Again, we're going to talk about some communication techniques that will be helpful when you have families come in who sort of have expectations that maybe you're not gonna meet exactly with an antibiotic prescription. And then we'll have some time for questions at the end. So hopefully you guys can learn about, from the takeaways, you can learn a little bit about the PCORI project. You can learn, it turns out, little spoiler alert, that if parents come in expecting antibiotics, you're 26% more likely to write that prescription. I was literally shocked when I learned that. I did not think that was true. I was like, no, I'm just gonna write a script when it's indicated. Turns out that I'm human, right? So we're all human. We're influenced by people coming into our clinic. So we're gonna also talk a little bit about how to avoid unnecessary prescriptions and while keeping patient satisfaction scores high. So it's complicated, right? Because antibiotics save lives, but they're not benign or risk neutral. Resistance is on the rise, and we're not, Dr. Balan teaches me, we're not making new antibiotics. So what we have is what we have. So we have to be really good stewards of what we have. It's also expensive. There's significant cost to overprescribing. More hospitals and resources are required. Society's at risk also for overprescribing. And it turns out that most of the prescriptions, I'll share with you here, most of the prescriptions are written in the outpatient setting for antibiotics. More than half actually are that are written are inappropriate. That's a huge number. So when PCORI sort of threw out this call for us, we thought this might be a really good project for us to work on. So I'm going to talk about that in a second, but lowering the number is definitely the best way to tackle antibiotic resistance. So the goal of antimicrobial stewardship, and we have a team here that helps us, and we've already done a lot of work in the emergency room and the inpatient, but this is really our first major institutional project on the outpatient side, is to optimize the use of antibiotics, improve patient outcomes, while reducing resistance and minimizing harm. So that's sort of the goal of stewardship. So what is this PCORI project all about? Well, Patient-Centered Outcomes Research Institute is a federal organization that is interested in keeping patients and families at the center and really affecting outcomes. So they put a call out for appropriate antibiotic prescribing for children with acute respiratory tract infection, because it turns out we have a lot of work to do there. The project's actually 3 years. We're well into it. The sites where this project is going to go live is sort of, I think of it as outpatient, but you guys may not like, that includes emergency room, urgent care, Phoenix Children Pediatrics, and our division, Gen Peds. And it turns out that when we're going to look at our data a little bit from Phoenix Children's, but we have high variability for these prescriptions across clinics and across providers. That shows us we have some work to do. So where are these other centers that are participating in this PCORI project? Because lots of other centers around the US are participating. And you can see, as it's kind of a smaller slide, but as the color gets darker, more sites are participating. So 21 health systems across the US are participating in this. And just in Arizona alone, Phoenix Children's, Valleywise, and St. Joe's all have projects going. So we're going to reach a lot of patients. 1.6 million patients will be touched by this project. So the principal investigators are me, you guys just met me, and then Dr. Vadia, who is traveling outside the country right now and couldn't be here, but he is our Senior Vice President and Chief Medical Information Officer. And if anyone knows Vinay, you cannot say Vinay without dashboard. So he decided when this project came up that he was like, well, let's show the data, see if we have any room to improve. So of course he got right to work and created this dashboard. And you can see, I don't know if my clicker works, but you can see in the box that over the last 2 years, in all of the urgent cares, emergency rooms, Phoenix Children's Pediatrics, and our division, we saw over about 143,000 unique visits for acute respiratory tract infection. That's a lot of visits. So clearly we have a lot of opportunity here. So when you look at what we consider off guidelines, so I'm going to go more into the project, but specifically, if you see a child for a viral respiratory infection and you prescribe an antibiotic, that would be off guideline. If you see a patient with a bacterial infection and you prescribe a broad spectrum, which we're considering anything beyond amoxicillin to be broad spectrum, then you're off guideline. And it turns out of those about 43,000 visits, 20,000 were off guidelines. So there's definitely room to improve. So the core elements of this project, we're going to obviously measure the data. Vinay, I didn't even show you, but the dashboard goes on for miles. So we have lots of data there. And the two main things we're trying to do is decrease the rate of antibiotics that are going out the door for likely viral infections and decrease the amount of broad spectrum antibiotics that we're writing, specifically for acute respiratory tract infections. This project may expand beyond that, but for right now, that's what this is about. And it turns out actually that we're actually doing a fairly good job of not writing for antibiotics in a viral situation here at Phoenix Children's. I think when we last looked, our numbers were about 86% on guidelines. So we're doing pretty well from that perspective. As far as broad spectrum, we have a little bit of room to go. So that's really where our project is going to focus. Well, how are we going to do that? We're going to use evidence-based diagnosis and treatment. That's what we do every single day here, right? We're going to be in the patient room. We're going to use evidence-based. We're going to diagnose and we're going to treat. We're going to also talk a little bit about how like delayed prescribing and watchful waiting might be something that's reasonable to consider. And then we're going to definitely talk about some communication strategies for clinicians in that room to decrease the rate of antibiotic prescriptions that we write when they're not indicated, when they're unnecessary, knowing that sometimes they are very necessary and it's important, but knowing that we're doing it a lot sometimes when it's not necessary. But in addition, continuing patient satisfaction scores to remain high. So I'm so sorry to alert you, but we will have an alert. I will tell you, it's one alert. It only gets triggered if you write for a broad spectrum in a situation where you have an acute respiratory tract infection. So sometimes there may be indications, right? Like you might have a pen allergic child, or you might have a treatment failure, or you might be treating not an acute respiratory tract infection and you want to write for that antibiotic because sometimes, you know, patients don't always come in for one thing, right? You might be treating a second thing as well. So we have a justification. You can choose what your justification is, but it is an alert to remind you that amoxicillin is the mainstay for most of these infections if they're bacterial. We also have an antibiotic cheat sheet, which I'm going to show you in a second, that will be embedded into the notes that was created by our antimicrobial stewardship team here at Phoenix Children's. We're going to provide some feedback. I'll show you a little email that will be coming out. And then we have an LMS module. I know everyone loves their LMS modules. I will tell you, we tried to keep it brief. Hopefully it will be fast. It will go live the week of October 6th, actually October 8th to be exact. And hopefully everyone can click through pretty quickly. This is the cheat sheet. So it might be a little too small for you to see all the details, but you can see here that we have the most common conditions for acute respiratory tract infections that are bacterial. So we have otitis media, sinusitis, strep, community-acquired pneumonia. And it talks what are the major pathogens that we typically see for this infection? What's the first line choice? If they have a minor allergy, what do you choose in place? And then if you have a treatment failure, what do you recommend? And duration. I will tell you, we have a lot of improvement to do in duration as well. Most of us are writing prescriptions for minimum 7, most 10 days. And the recommendation is far less than that. So for some, you know, sometimes like strep is 10 days, that's fine. But there's other for otitis media 10, but depending if they're older, shorter time. So we have some room to improve on duration. So this will be embedded in the notes in emergency room, urgent care, Phoenix Children Pediatrics, and Gen Peds. So you will be able to see this if you want like a little reminder about treatment. And then there will be emails. I know we'll have to decide how often we send these, but the emails will remind you that maybe you did prescribe something off guideline. And you can see it's also a little small here, but it will come from the report hub. And basically we'll have the patient's name, who saw them, what location. You'll get a personalized email, but also your boss or your division chief is going to get an email that does your entire division and sort of also how everyone's doing compared to each other. So just for complete transparency's sake, we will be looking at numbers. And you can see that in this situation, this first one, it was attending in Scottsdale Clinic. They did see someone diagnosed a bacterial infection, but wrote for a broad prescription, broad antibiotic, and they used Augmentin. And then you can see what their diagnoses were. So in the future, like when you get these emails, you can also click on the smart sheet or smart chart link and sort of look up. I will tell you there's a little glitch in the sense that if your note's not complete, it will sometimes look like you wrote for a broad spectrum, or you might wrote for a narrow spectrum, but you didn't code acute otitis media yet. So we'll deal with the details that come through as we go live on this project, but hopefully it will be helpful feedback. I will say that we did this for the pen allergy project at Phoenix Children's here in Gen Peds. And it turns out the majority of patients who carry a penicillin allergy don't actually have a penicillin allergy. And we were actually able to decrease that rate by addressing that. And we got feedback. I will say we stopped getting it so frequently because it was too much, but it was helpful in the beginning to remind yourself to talk about that. Okay, so what do we do? Okay, so we have patients coming in and they have expectations and we're sort of limited on time and they have what they want and you're in a busy clinic or an emergency room urgent care. How do you address the concerns that are in front of you in an effective manner? Well, it turns out that there was a large LA study, about 27 practices, 38 pediatricians within those practices. about 10 to 15 visits per pediatrician, and over 500 study visits. So a lot of visits, we collected data. And when I say we, this was not me, but it was a study that was reported. They looked at children 6 months to 10 years, specifically with cough, sore throat, and nasal congestion. Those are very common complaints for upper respiratory infection. They did a pre-visit questionnaire for the parents. They recorded the videos, and then they did a post-visit for the parent satisfaction questionnaire and a provider post-visit. And what did we learn from that data? Well, like I gave you a spoiler alert in the beginning, turns out that if the provider thought the parent had expectation for antibiotics, we were 26% more likely to write for a prescription. So that's pretty heavy. That was really not a statistic I was thinking was true, but it is. So in addition, if you documented rhonchi or wheezing on an exam, you're 17% more likely to write for an antibiotic. And this is interesting too. Turns out we're human. So if parents report being very anxious about their child's illness, that we're 9% more likely. So, one of the tricks to kind of know, are they expecting antibiotics, is do they use a candidate diagnosis? And it turns out that if someone comes in, and you've all heard this probably before, my child, I think, has strep, was exposed at school. So they're giving you an explicit diagnosis. They stated the name, they told you what they think they have. But it turns out that what most parents actually do is an implicit diagnosis, where they'll say, hey, Johnny has really thick green mucus and had really high fever, and he might look good now, but he was exposed to his cousin who has sinusitis, and that all sort of leads you to believe that they're sort of trying to paint a picture, right, for antibiotics, or they're trying to say that they have this diagnosis. So again, this is not to villainize anybody here. This is just like parents are nervous and anxious, and they want to share all the information with you. And so, but to know that when they do share those diagnoses with you, when they offer a candidate diagnosis, that they are 25% more likely to expect antibiotics. So knowing that information, meaning that when they come in and they share that, that is them sort of communicating to you that they expect antibiotics at the end of this visit. And then it's for you to know, oh, okay, I know now when there's an expectation that there's an antibiotic, that I'm more likely to write that. So again, this isn't about not writing any prescriptions for antibiotics. It's just about in the situation where it's appropriate, of course, we write the antibiotic prescription. But there's lots of times, right, when it's a viral infection, and it's sort of a hard call sometimes because we don't have as many tests, right? A lot of it is clinical. We're hearing the story, we're listening. We don't do a ton of testing in the outpatient space to know. We don't do, we'd have strep for sure, but we don't have a ton of other definitive diagnoses techniques. So how do we, so if you determine that they don't need antibiotics, but they expect them, well, what are you supposed to do about it? So this is what we're going to chat about today. Okay, so this is a 4-part communication strategy. So the 4 major things are, we're going to review physical exam findings. That's important to do. Deliver a clear diagnosis. So tell the family what you think they have, not only what they don't have, but what do they have? And then your treatment recommendation should be negative followed by positive. I'm going to give an example of this, but specifically a negative is, this is not a bacterial infection. This is nothing to worry about. This is an infection they're going to get better from, and not really sort of using a lot of sort of, well, what do you do about it? So the positive, and I'm going to come, so the negative is like, this is just a cold, an antibiotic won't work in this case. Specifically for the negative, if you just end with that, parents have a lot of questions and that visit goes longer. So that's not to say that you shouldn't say that, but follow it up with a positive recommendation. And specifically that would be raise the head of the child's bed. This will improve drainage from the nose, or whatever other recommendations from a supportive care standpoint you are. Brittany and I were just talking about this morning, and I was reminded that in the emergency room, in urgent care, in clinic, we have the pressure of time and patients are waiting for us. And so we can sometimes be very quick to say, this is a viral infection, move on, your child's fine, and forget that they came and they need information about, well, what do you think it is? And what do I do about the symptoms that brought me here today? So spending some time on the positive recommendation, turns out that if you do that, you end with the positive recommendations, that you actually write antibiotic prescriptions less. It's viewed as a win-win for parents, and less time is needed for the patient visit. Like if you end with the negative, Parents are definitely not going to be super happy. They're going to have a lot of questions and really question, well, then what? So instead of ending with the negative, going on to the positive as well, really helps. So in addition, contingency plans. So what if? So, okay, so I think this is a viral infection. We're not going to do an antibiotic prescription today. Well, what do we do? Okay, well, we watch out, right? Like, so if you have a period of time where you improve and then your child improves and then they get worse, that's concerning to me. If they had no fever, but 5 or 6 days into it, they have high fever, that's concerning to me. I don't think this ear infection, we can watchful wait in this situation. I don't know that we need an antibiotic. However, if they develop fever, more pain, not eating well, vomiting, like worse symptoms, I'm going to send a prescription to your pharmacy and you can fill it then. It turns out that actually prescription, it's a very low percentage of the time. I think it was like 17 or 20% of time that prescription gets filled. So you still wrote for it, but you just provided some reassurance to the family and they didn't actually even have to fill the prescription. So the contingency plan is huge. So Brittany and I are going to model some conversations here. And we're going to do 2 visits. And the first visit is a 4-year-old female, neurotypical, not really any other past medical, comes in with some viral upper respiratory infection symptoms. And she is definitely expecting antibiotics at this conversation. And what I want you guys to do while we're talking is to think about this 4-part communication strategy. Did I review the physical exam findings? Did I deliver a clear diagnosis? Did I do a 2-part treatment recommendation where I didn't set a negative, but then followed it with a positive? And did I talk about a contingency plan? We're then going to chat with Brittany and see how I did on that. And then we're going to have a second case where we're going to go in for a little bit more medically complex child. So I'm going to go over here. So hopefully you guys can still hear us. Did you start?
Yep.
Okay. So, hey, I'm nice to see you. So tell me what brings you in today.
So my daughter Audrey has had a runny nose for a few days. She's not feeling well and is running a fever. So I suspect she may have an infection.
Okay. Thank you so much for bringing her in. Has she had any difficulty breathing or trouble staying hydrated? She's eating okay?
Those things are going okay.
Okay. Well, I'm gonna examine her and see what we find here, okay? Okay. So I examine Audrey and look at all the ears and throat and listen to her lungs and all the things. Okay, Brittany, thank you so much for bringing her in today. Obviously, we would go into a lot longer of a history, but we're on time here. So I think Audrey is fine, and she has a viral infection, and it's going to probably run its course, but I think you guys are going to be fine.
Wait, so you're not going to prescribe her any medicine? What about an antibiotic?
So she doesn't have a bacterial infection, so there's really no need to write for an antibiotic here. So her virus will just get better on its own, and we don't really need to do anything.
I'm a little frustrated. You know, she's not feeling well. I don't have to bring her back in. I think we'll just go to the urgent care on the way home and see if they'll give us some medication.
No, I don't think they're going to really do anything different. Like, I just listened to all of the things, and she looks good. And I unfortunately, I think she just has a viral infection. I know that's hard to hear, but she'll get better.
Okay.
Okay. Pause. So, first, I'm going to ask Brittany, how did that?
I think a little dismissive, you know, when parents, their child doesn't feel well and they come in. Historically, they've often been given a medication. So it's a little frustrating to hear no with not a lot of follow-up of what they can do to help their child.
People's thoughts in the audience about like, what did I do? All of those things. What did I miss? What could I have done better? Yeah, Shayla.
I'm a triage nurse, and we hear all the time that they say they didn't do anything. And that's exactly what I see is like, she feels like you did nothing, but you're like, I did do something, it's saw the patient. So I think like coming back around confidence will help.
So for everyone to hear that, Shayla shared, and she is kind of a plant, I guess. She came to support us, but thank you for listening, having a question. So Shayla shared that there are triage nurses and get these complaints all the time from families to say that, you know, well, we did take them to the urgent care. We did take them to the emergency room and they did nothing. as a very common complaint, right? So how do we combat they did nothing? How do I address that concern? Any thoughts? Yeah.
Well, a couple things. Sometimes I see people deliver the diagnosis before the physical exam. And that does feel like nothing because like, did you even look at my kid before you like came up with the diagnosis? Even though you are making lots of observations, of course, just like sitting in the room with them, but I would always discourage against that. And then you said I did all the things, which maybe you would have gone into more detail if there was actually a patient here. But like, I do think it's better to talk through what you're doing, when you're doing it, what you're seeing. They feel that you actually did pay the appropriate attention, did look at the ears, and I'm looking for ear infection, and I see clear tympanic membranes, so that tells me there's no ear infection. Like just a lot more details about what you're
actually in just a second. So Dr. Shamanar definitely shared very helpful information that you might have a really good idea of what this diagnosis is before you examine that child. However, the point of that coming in, right, is to look because you don't know what the ears look like. You don't know what their throat looks like. You don't know what their lungs sound like. You have done this a lot for a while, maybe some of you in the room. And so you think you probably know, but I do think it feels a little dismissive to sort of give a diagnosis beforehand. And then while talking through your exam, I do that all the time. Talk through your exam while you're doing it. Can we come over here really quick? I think I had someone over here. No?
Oh, yeah.
Yeah.
Well, just two things. One is like when someone, she brought her child to you and you're like, oh, she's fine. It's like, I wouldn't bring my fine child in. Why are you saying she's fine? But the other thing, your question, I call it out. I'm like, it feels like we're not doing anything, but the most important tool we have in pediatrics is time and watching the kiddo in the hospital. And so I'm watching them, and it's called watchful waiting. And it's actually like the best thing we can do. Like just call out, like it feels like we're not doing anything, but actually this is what we're doing.
Yeah.
Just
So calling out what you're doing is helpful for sure. Sorry.
The things I've noticed with working with patients and parents previously was also letting the parents know, hey, this is what I'm seeing. Here are the red flag symptoms I want you to look out for. Just acknowledging that they know their kid and know when something's wrong or something, being able to like communicate so that they feel more involved in that care.
Yeah. So giving a little bit more help with the family about what to watch out for. What are the red flags? What would you be concerned with, and when should they come back?
And explaining your understanding of the situation. And
Yeah, absolutely. Any other, so I think those were amazing feedback, and I know it's really hard to get like interaction in Grand Rounds, so I so appreciate that. Thank you all for participating. So I think you guys did a really good job of identifying some of the things I could have done better. So I'm gonna try this again. So I have a 15-year-old medically complex child. She has an ear infection, but the parent expects broad spectrum antibiotics, which in this situation would be anything above amoxicillin. So again, we're going to do the 4-part communication strategy, and it may or may not be different. You guys tell me. So we're going to start again with this conversation. Tell me what brings you and Brookie in today.
So my daughter Brookie hasn't been feeling well. She's had a fever for a few days. She also has epilepsy, and anytime her seizures spike, sometimes we expect that she's sick or not feeling well. So I wanted to get her checked out.
Okay. So at this point in time, have you seen any difficulty breathing or not tolerating your needs?
She's been doing okay with those.
Okay. Has anyone else around her been sick?
No, her sisters are fine. She's been doing okay. We really try to avoid coming in at all costs because I don't want her to get something in the waiting room. But just with her escalation of seizures, I really felt like it was important to be seen.
And what are her current symptoms right now?
So she has a fever. She's a runny nose, really lethargic. You can just tell she's not feeling well.
So is it okay if I examine her?
Of course.
I'm gonna wash my hands. Okay, so wash my hands. So yeah, I can tell just by looking at her that she doesn't feel well. So I'm sorry that you had to come all the way down here and bring her to me, but I really appreciated that you did because it's really hard to sort of make a diagnosis over the portal or over email or over the phone. So thank you. When I'm listening to her lungs, actually, she sounds pretty good. I don't hear a differential between the two sides. I don't hear any wheezing, crackles, or any concern for decreased respiratory. I see she's breathing well and she sounds good. When I look in her throat, it's a little bit red, but sometimes I see things that concern me with strep, and I don't see those things in her mouth. But unfortunately, when I look at her ears, I do see a bulging disc, and when I use my insufflator, I don't get good movement. And so I'm concerned that she has a ear infection. Otherwise, she looks well hydrated. I know she's a little tachycardic because she doesn't feel well, but she's not febrile for us in the clinic here. And so really the main concern I have is her ear infection. So we have a couple options here. At the beginning, we could sort of do watchful waiting. I think the reason I'm not going to is because Brookie is high risk. She is not able to sort of, she's not ambulatory, so that means her lungs are a little bit higher risk. So if she has a bacterial infection, or if she has I anticipate, so let me start from the beginning. I think she probably has a viral infection that caused fluid buildup in her ears, that then caused an ear infection. Okay. Then I'm worried that because she's a viral infection, she's higher risk for having a bacterial infection in her lungs. Right now, she sounds good, but I know last year she had a pneumonia and it was really tough. She ended up in the hospital. So we definitely don't want that. So in a situation where a child is completely no other diagnosis, she has an ear infection, I could sort of just wait that out and see if it's going to get better on its own. But for Brookie, I'm not going to do that. So we are going to prescribe an antibiotic today, and I'm going to use amoxicillin. And we'll do twice a day for 10 days, and that will take care of, if there is strep, which I don't think there is, but it would take care of strep as well. And hopefully ward off any pneumonia that could potentially be down the pipe.
So I'm glad you're going to treat her, Dr. Wendy. I don't want to end up in the hospital, but as you know, amoxicillin hasn't been effective for Brooke in the past. So I would prefer we just go straight to augmented.
Hear what you're saying, for sure, absolutely. And I understand that she may not respond to this antibiotic. My hope is that she will. It should work. That to say, what I would expect if it does work is for the next couple days for her fever to come down, for her to look better, for her to tolerate her feeds, for her to sort of feel better. I'm hoping in the next 2 to 3 days she's better. If she's not, I'm very open to that conversation. So if she develops a higher fever, or fever comes back, fever goes, then it comes back. She has any respiratory issues. She's not tolerating her feeds. She doesn't look well. In the next couple of days, she should be better. If she's not, I want you to know that. You can then consider, if she's clinically stable to stay home, I could consider changing her antibiotics at that moment without bringing you back in. If she has any respiratory, like breathing difficulty, she's probably going to need to be seen because I'm nervous that I don't want her to stop at home. That's that. So.
I'm okay with that. I like the fact that we have backup plan. You know, I'd love to have to not bring her back in. So thank you for the contingency that we can have just in case.
And we want to make sure she's okay. So keep in touch with us and just make sure if she's not well, let us know. I also love updates. If she is doing well, you can let us know as well.
Sounds good, Dr. Wendy.
Okay. All right. So I'm going to ask Brittany, how does that feel?
Much better. You know, I think parents just want to feel heard and validated. I also think parents are very smart. And so giving them, you know, clinical information in a way we can understand, you know, not assuming they won't understand. I think it's really helpful because you explained your why. It made a lot more sense to me than just saying, oh, she doesn't need amoxicillin or doesn't need augment, excuse me. Yeah.
What else did it feel like? What else did I do or not do that made you feel sort of like your concerns were heard?
Compassion. You're always so good at this, Dr. Wendy, of obviously you're there to treat our kids medically, but also showing that human side of like, we really care about her. You know, good job as a mom for bringing her in. You had the right instincts. You know, that always feels good as a parent. I liked that you explained the things to look out for. You know, if she's starting to have more respiratory issues, we want her to get seen and why. You know, we know you don't want her to be hospitalized, but these are some things you can do and we can look out for to prevent that. It really just comes down to parents' feelings being validated because we're worried, especially having a complex kiddo, like everything is more complicated. So just that reassurance and giving us the confidence in caring for our children is really helpful.
And what Brittany always shares with me is we've done all the things. Like we've done a lot. By the time we go to the emergency room, we've done all of the things. Like we tried everything. So to say just, you know, rest in fluids, you know, is like kind of dismissive, right? So sometimes I'll say, I know you've done all the things. What are the symptoms that are the main concerns that you have at this moment in time? What makes you worried? And it might be that right now she's okay, but they're worried because last time they were in the hospital for 2 weeks and it started like this. And they're trying to do everything they can to not do that. So sometimes I just have to ask, I can tell that there's something bothering Brittany, but I don't know, you know what I mean? And like everyone has their life, right? So they have lots going on. So she might say, we have a wedding coming up and we cannot have Brooke sick for that wedding. She needs to be good. And what always makes her better is antibiotics, you know? So again, not here to just sort of like fight for prescriptions to make parents happy. The point is, right, to provide really good medical care, but also addressing concerns that families have. And so if the time wasn't to write a prescription, but they were worried about something, giving them a contingency plan about what to do if it doesn't go the way that I hope it would go.
Yeah, and I just on that note, you know, the contingency plan is so helpful. I admit there have been times we've come to the ED and there wasn't anything to quote unquote treat with medicine. And they're like, oh, just bring her back. And I'm like, do you understand what that entails? I was like, a 9-hour wait in the waiting room, like super stressful. So when appropriate, a contingency plan is so helpful to families.
And I think the contingency plan is obviously a lot easier to institute in a general pediatric clinic because you have a relationship with the family. So it's harder in the emergency room, harder in the urgent care to have that kind of trust and follow up. So use your primary care offices, you know, say, if they're not better, please call your primary care doctor. I know that you guys do that, so it's on all the paperwork, but really saying like, hey, and if you don't have a relationship with a primary care physician that you feel is going to address your concerns, get somebody else, you know, that, not that we're, you know, encouraging switch, but it is, you need a relationship, right? You need a relationship to feel that trust. So I'm going to open it up to the room. Who has thoughts or comments about how that either went well or could have gone better, or thoughts about how that was different?
You validated her, like she looks like she does not feel good. I think that's important.
Yeah. As opposed to like, she's fine. She's fine.
I like how you addressed the past experience with like a broad spectrum antibiotic too, because that's something I've struggled with in clinic. Say, oh, I've gotten this in the past at work, or we need to go on a trip and she got better last time with antibiotics, addressing that as valid at that time, but moving on to what's present now and what's your concern about.
Right. So I think it is important to validate sort of what their concerns are. And sometimes you don't know, but when she says, well, they got it before in the past, it gives you an opportunity then to talk about this. Hopefully the situation is different. And if it's not, this is what we're going to do.
I like talking through your clinical reasoning in the right setting. Sometimes it can seem like you're being wishy-washy, but most parents respond to that because it shows that you're thinking through it. You're not just acting instinctively based on one thing. So we could watch full weight, but in this case, given the situation, I'm less inclined to because, and I think it really helps them understand that you're putting thought into it.
Yeah, how was that when I was like explaining those things? Is that helpful?
Yeah, so it kind of goes back to what I've told you before, like parents are smart, and especially in this case, having a complicated kiddo, like you become pretty versed in their medical needs. And so, you know, by explaining your reasoning, assuming that I'm understanding you, using some of that medical terminology, like I wouldn't underestimate parents. Like we want to know that stuff.
I do also a lot of like watching their face because I can tell they don't like what I'm saying. Sometimes they'll be like, seems like maybe you're not okay with that plan. Okay, yeah. So tell me what you're worried about, because they also I'm sure this has happened to you guys, but like literally you finish the whole visit and then you're on the, oh, by the way, and the major concern comes out as you're walking out the door. That happens to me all the time. So I usually start every visit with, what can we talk about today? And then at the end, did I address everything? Like, is there anything you're still concerned about? Because they don't want to, sometimes, I don't want to speak for you, but if you want to, like, maybe you don't want to say out loud what you're worried about, or maybe you don't want to burden us. I'm not sure actually what that's about sometimes.
I think especially going back to the complicated kid issue, sometimes you remind us of other things. Oh yeah, by the way, this is also going on. Also having a child that doesn't use language to communicate, it's nonverbal. Sometimes I don't want to say certain things in front of her that aren't appropriate. And we always assume intelligence. And you're so good at that, but unfortunately some providers aren't. Say she's in front of a child that wouldn't say that in front of them. They were verbal and communicate typically. So
being careful about that as well. Yeah.
I think now this is a great point for Adrian, but the other thing that is helpful sometimes is to explain why we don't want to go with a broad spectrum antibiotic. you know, obviously assuming the understanding that everybody knows good antibiotics, right? Like they kill bacteria. Just make sure that there's also an understanding that antibiotics are not magic bullets, right? They're not going to differentiate good bacteria and bad bacteria. That always kind of, you know, puts it in perspective that what you're talking about is you want to strike the balance where you're killing the bacteria that you're concerned about, but without all the other bacteria that you need. That's why you need to fill it as narrow as possible, because you know that with an infection like this, these are the common bacteria that cause that infection. So there's really, we have to be careful with not going broad and kill all the other bacteria that could be infectious.
See, this is why being a division chief for infectious disease, because he is reminding me of one of the most important parts is that we have bacteria all over, right? And there's some good bacteria and some bad bacteria that cause disease. And if you do a broad spectrum, it takes care of all the bacteria. And then we can have like issues like diarrhea, C. diff, you know, all sorts of unwanted consequences.
And other than the microbiology of the antibiotics and what they're going to kill and not differentiate what you're targeting and what you're not targeting, is also talking about the side effects, the other side effects of the antibiotics, right? Like, for example, augmentants. This is going to be, you know, the main issue that we always face in terms of amoxicillin versus augmentin. You know, talking about the side effects of clavulanic acid that's added to the amoxicillin and how much GI issues it causes, with besides its effect as a broad spectrum antibiotic. So not to scare the parents, but just to tell them and explain to them why you're trying to go as narrow as possible and target the culprits, basically.
So really quick, let me just add to that point that I think that sometimes because we have that knowledge, or we have that knowledge, we don't necessarily think it's important to impart. But I think what Brittany is teaching us today is that parents want that information. So if I said to her, well, the reason we're not using augmentin is because I'm worried it's going to cause diarrhea and cause more trouble. And the amoxicillin is actually going to target the antibiotics or the antimicrobials that I want it to do. And then we're sort of in addition. So most parents are like, treat the patient that's in front of you. I care about antibacterial resistance, but not right now. You know what I mean? So like using your antibiotic resistance conversation in this moment, it might have a place, but it shouldn't be the only place. Because if all you say is we're trying to decrease, they'll say, well, I'm not going to get political here, but like herd immunity might not be something that people are so concerned about at this moment in time. So definitely focus in on the patient and why that is actually beneficial for her. Not that you have some big guns that you're just not giving her because you don't want to. Actually, there's a reasoning behind that. So sorry, there was a question over here.
I was just going to say the same thing, is that I've had patients tell me, I don't care about antibiotic resistance. I care about my child. And so I feel like Dr. Balan's comments are much more helpful in clinical practice.
And I will say that it's not a one-off, because we did a parent focus group on this to sort of get some thoughts about what would be helpful to have conversations about. And one parent shared, well, I am actually concerned about resistance because my child has a central line and I'm worried about that. We talk about it with every admission. So please do not use these if you don't need to. So it actually is helpful. So I think, you know, again, when it comes to conversation, it's not one all end all. Do you know what I mean? Like it really is tailored to, but have all of these sort of tools in your toolbox to talk about it. And if you can tell this family is not going to hear the resistance conversation, don't like tread down that path only. You know, address that concern specifically for them. But it might sound dull because you might say, remember last time when she came in for a urinary tract infection and we had to escalate and we are getting to the point where I'm nervous that we now won't have antibiotics in the future to treat her. So we do want to be good stewards of our antibacterials. Yeah.
Maybe Brittany, and you could comment a little bit about how do you recover a conversation that started to go down the wrong way? Because it can be that, you know, you as an initial provider started and you lost them. It could also be that you're the second or third doctor coming in after a medical student or somebody else has already turned the month off. And okay, how do you recover that? Because it's a lot better to, you know, to start from the beginning with you know, the caring and the compassion. And sometimes if that doesn't happen, you have to figure out, well, what's the best thing to do now?
How do you mitigate damage and
Sure.
turn it around?
And that's such a good point, you know. I love that this is a teaching hospital. I love that we have residents come in, but when you're tired and exhausted, and you told the resident, the attending and the specialist, and you're like, I've already explained this a bunch of times. I just think maybe even just pausing and recognizing, like, I'm sorry, I can tell you're upset. I'm sorry if you weren't heard, but what can I do to help you now? I'm listening. Again, just all of that validation. And I know you guys are really busy, but not making the parent feel like you're rushing through it. Like, all right, we got to get this done. Next visit, next kid. Just pausing and acknowledging that you see that they're upset. I would probably be upset too. Sorry that you feel that way. Let's pause and start over. What are your concerns? What can I do to help?
Especially if there's something that the family feels like has not been addressed.
Yeah.
So they're like, we've met with 3 people and we still feel like our major thing is not addressed. And now you're going to come in and just validate everything they said. We still haven't gotten our concerns. I think just starting really open-ended and saying, hey, make sure we're on the same page. I know you've seen a lot of people and told your story already. Sometimes what I do, honestly, in the beginning, because I have obviously patients who have book-long histories, I'll say, I'm going to review with you what I know. And I'm sure I'll miss things along the way, but this hopefully then communicates to the family that I took the time to read their chart and have some idea of what's happened before. So I'll say to Brittany, I see that Brooke has been to the emergency room 3 times. I see that in the first time they did this, and the second time they did this, third time she needed admission, and this is what happened. It sounds like this, and this was instituted. We're now doing follow-up. Did I get everything right? Did I miss something? And I don't know how that feels when someone takes the time to do that, but they might not get all of the details, but is that helpful?
Yes, because the exact opposites happened before, where they're Googling your child's diagnosis as they're walking in the room, not really feeling like they took the time to history. So it is helpful. And especially when you have a kiddo that has a gazillion specialists, there's a lot going on. So it just makes the family feel like you care. Right now you're treating their child. You're only focused on what their child's going through. And then if there's any other conversations that maybe I'm not happy with, I'm not getting the medicine that I want, the conversation will go better because I felt like you really cared and listened and validated my feelings.
And sometimes there's a trigger. So if I say, most kids do this, that could be a trigger for patients who have children with medical complexity or sort of rare disease. I know what you're saying is probably true in your book, and the likelihood is that mostly happens. Our child, that is not true. And so I'm not saying that you don't sort of share with them your thoughts about medicine, but I think also sometimes saying that might feel.
Yeah, I think I'm fine. How she mentioned, that's like nails on a chalkboard. Your child's fine. Well, if they were fine, I wouldn't have come in here. Waited for the waiting room or whatever,
Yes.
Sometimes the visit's not going well, but I don't know exactly why. Like, was it that they don't like what I'm saying or what the other team has said? Do we miss the mark? Like, it's hard to know. And I don't think anyone likes to be told, like, it looks like you're mad, or like, cause like, you don't know exactly if they're mad or they're scared or they're sad or what it is. So I just usually say, it seems like this visit hasn't met your expectations. Can you tell me how we could do better, or what it would take to figure this out better? And then I allow them to just kind of help me figure out which one of these things. And not every time, like, can I fulfill exactly what they want to happen, but I can at least explain it better and figure out what's going on. So, let's take a pause. I know you've been here for over an hour, but let's help us figure out how we can address this better.
I think calling it out absolutely is so helpful for me.
Yeah, and I agree. Looks like you're mad. Maybe just say, are you doing okay? If you can see that they're flustered or upset, It's a good point.
Okay, perfect. Well, let's get back to quick conclusion. So first of all, I just want to thank you all because you never know, it could be crickets. People might not want to say anything. So I appreciate the conversation here. Is really awesome and energizing. So hopefully today you guys learned a little bit about antimicrobial stewardship and specifically what Phoenix Children's is doing in the outpatient space. We have this $1 million project, which I'm very proud about, and it goes live. 2 of the Phoenix Children's pediatric sites we were supposed to just go live January 1st, and we decided let's have 2 clinics go live as a pilot on November 1st to give us some information, because There's going to be a lot of people this is going to affect. Everyone in the emergency care room, urgent cares, all the residents that are rotating, all of the places, and all the Phoenix Children's Pediatrics. So 2 PCP sites will go live on November 1st. Then most of the institution will go live on January 1st. And then the rest of Phoenix Children's Pediatrics will go live on March 1st. And really what will change for people is just that cheat sheet will be in the note. The alert will come up if you try to write for a broad spectrum. So you do have a way to justify. We're hoping to get some data. We're also, just as a plug, we're going to do one of the 2026 PSQ shared PCMG goals is going to be this project, which I'm super excited about because a lot of them, not to be, disparage our hospitalists, but are sort of discharged by 2, which I'm sure you're happy to sort of give a little leeway on. And as an outpatient pediatrician, I don't have much control over that, so it's always hard. So for everyone in the audience to know that probably one of the shared PSQ goals will be this project. And there's a lot of support for this project, so we will meet our goals. And then hopefully you guys learn some communication techniques that you can use in the clinic to help address patients' concerns and while still maintaining satisfaction. And then there's some resources. So Pecora, we have an index page that lists the little sort of facts about the project. There's the dashboard if you want to go check it out. The cheat sheet is the link there, but also it will be in the notes. My email, and then we have a Pecora ARTI email as well if you guys have questions or concerns. All right, thank you guys very much. Oh, sorry, more questions. Oh.
There we go.
Oh, sorry for your QR code. Yes, please. Yes, please. Awesome. And I don't know that we have anything online. Questions online.
Oh,
sorry, I didn't check.
Okay, we have one here. Okay, this is an interesting thought. Will allergy delabeling be incorporated into this project? Like maybe if you're prescribing broad spectrum due to a documented allergy, it automatically triggers a referral to allergy immunology for allergy delabeling.
I love that idea. We did, as a general pediatric, do an allergy delabeling project, and it really was very successful. And it definitely is something. Christy, did you want to comment on that? Sorry, you raised your hand.
Yes. Sorry. We do have an algorithm that if the allergy is based on family history or a side effect, then that is a no risk allergy that could be delabeled in the moment. And then the other are low, medium, and high risk. It might consider incorporating your allergy colleagues, but they're happy to help with delabeling. And I think it should be incorporated because 90% of penicillin allergies are false. So.
Yeah, so that's a really good point. There's been so many like offshoots of projects that we've been thinking now that we have this dashboard and this information. So allergy delabeling should absolutely be, whether it's right at go live, probably not, but in the future, absolutely. Agreed. Cool. All right. Oh, sorry. Oh. John's like, I'm not letting you go. No. We're going to use every last minute. Okay, sorry.
No, can you talk a little bit more about how the feedback's going to be used? Because that is a fascinating piece that, I mean, everybody's been preaching for, since before we were residents, don't overuse antibiotics, but there's never been any big brother oversight.
Yeah.
I mean, on the inpatient side there is, but on the outpatient side, there is absolutely no, other than just moral responsibility. No reason if you're in an urgent care or ED or whatever to not prescribe that antibiotic and have anything happen to you other than good patient satisfaction scores.
Yeah. So I will say all of the division chiefs and people who are like urgent care, emergency room, Phoenix Children's Pediatrics, and Gen Peds have all been involved in this project. So everyone sort of had their say. In addition, every one of those leaders will also get feedback at the division level. So how you're doing in the emergency room, each specific emergency room, how you're doing in urgent care, how our division is doing. We'll get specific feedback about overall how the clinic is doing, but also as we relate to our other members. So we'll be up against each other, you, me, and John. And you'll be able to see sort of how you're doing and what your overall rates are. Now, I will say in Gen Peds, where our like numbers are so much less than the emergency room. So in order to make a change, it's like not as impactful as an institution as like making a change in the emergency room or urgent care or some of the Phoenix pediatric sites. But yes, we will be giving each leader will get that feedback specifically about how you're doing related to your other peers, and then we'll have to see how that is shared with everyone. But the idea was to be fully transparent so that every provider can see how they're doing related to their peers. We can see that already right now on the dashboard. And if you went to the dashboard, you'd also be able to run your own report to see how you're doing.
The other thing to keep in mind is that obviously with the field of antimicrobial stewardship, the initial focus was inpatient, simply because it's better controlled, but also it's the place where you use a lot of broad spectrum antibiotics. As the field is evolving, there's going to be more and more attention to outpatient antimicrobial stewardship, not just out of goodwill, but also from a regulatory standpoint. So we're seeing it slowly kind of moving to kind of incorporate the outpatient world. So whether we're doing projects just because we know that that's the right thing or not, we're going to have to be accountable for our antimicrobial prescribing on the patient side in general.
And we just had our division meeting. I don't know, maybe a lot of you don't know this, but as a medicine committee, each of the divisions report out to each other about how they're doing at the provider level. And you're really supposed to use data to sort of see where your outliers are. And in this institution, it's been really hard to get, in general, not throwing anyone under the bus, to get provider level data. And this will definitely be a move in the right direction. Christy.
Related to that, is the provider level data for the attending or the resident or both?
It's a good question. So it's for the attending, because it's the attending eventually signing the record. So we can chat about how we dive into that further in our division, but yes, it's the attending of record and who signs the note at the end. Okay. All right, now you're all free.